Coming to, thanks for the introduction also. So coming to interventional studies, the second part of this presentation. So I must say that my previous speaker has already made my job easy. And today, basically, when we planned, when Ritik called me and they wanted to discuss this entire topic for just a quick revision of all the DNB students, and not only students but also for the faculty members, that how should we plan a study and what are the basic questions that keep popping up our mind whenever we plan some study. So the first part was observational study, the second part is interventional study. But the interventional study, my what is my basis is not like to teach everything about randomized control trial or what are the non-randomized trials, but the basic emphasis is that how do we actually interpose our interventional studies into real world data, and how do we draw some inferences. Like in the chat box I saw one question that for rare tumors, can we apply our real world data for regulatory approval? So that's a very important question, because whenever we see some tumor in which there is a lot of standard of practice, we are usually not in any trouble. But whenever we see some rare tumor coming to us, whenever we see some exceptional response, then we have to apply our clinical judgment rather than the established randomized control trials. And there comes the role of real world evidences. So with this background, I would like to start my presentation. That the initial part, as told by previous speaker, observational studies and interventional studies, this forms the two pillars of oncology. It's not now, it's since almost 4-5 decades, when initially the development of drugs in oncology was based upon the responses. Then people started realizing that there has to be some established randomized clinical trials. So it was initially observational, and then the world moved to interventional studies. So the first part has already been discussed. Now we will see about interventional study. So interventional study, basically it could be either two types. Basically it's either a study design, or whether we are referring to a study purpose. So study design means an investigation involving intentional change in some aspect of the status of subject. For example, if you are introducing a preventive or therapeutic regimen, particularly in oncology, like chemo prevention trial in prostate cancer, tamoxifen chemo prevention strategies was tried in breast cancer, or whenever we are doing some therapeutic regimen. So this is basically, we are designing an intervention study, or designed to test a hypothesized relationship, usually means like an experiment such as randomized control trial. So this type of intervention is basically, it's referring to a study design, while study of an intervention means referring to the study purpose, that whenever the study of a healthcare intervention may be experimental, or it could be an observational study. So broadly speaking, how do we divide this? This slide I have put just to make concepts of observational and study interventional studies, that they are two separate arms. So if there is no treatment, or no assign, the researcher is not assigning a treatment or exposure to anyone, so it's an observational study. And observational study, this part has already been covered in detail, so I will not go into detail in the interest of time. So if we are assigning some treatment, exposure, prevention, whatever, so this part is intervention. So interventional studies, again, it can be either uncontrolled or it can be controlled. So when we are comparing between the two types of intervention, or maybe more than two types of intervention, so it's an intervention randomly assigned study. If we are not comparing, so it's an uncontrolled single arm study. So now if we are comparing, so yes, if we are comparing, it could be randomized control trial, or it could be non-randomized control trial, depending upon whether they are randomly assigned with the possibility of, means each person getting equal chance of randomly going to the investigator control arm. So if it's yes, so it's a randomized trial. If it's no, it's a non-randomized control trial. We will see to these things in detail. So randomized control trials, again, we see, are the randomized units individual. So if it's if the units are individual, yes. If a particular set of population, if a group of admitted population, like in COVID time, if a lot of patients who are from the same group admitted in the hospital, and if they are randomized to something, so that is cluster randomized study. So based upon these types of intervention, and based upon randomization and which type of randomization, the interventional studies are classified. Similarly, if there is a risk or intervention, so it's an intervention or experimental study. It could be randomized, it could be non-randomized, or it could be pre-experimental. If it's an observational study, then we look for the control. If there are no controls, then it's a descriptive study. If there are controls, then it's an analytical study. And depending upon whether we are proceeding from cause to effect, effect to cause, or cause effect relationship, it could be cohort, case control, or cross sectional. So this thing has been covered. So now we come to my topic, classification of interventional studies. So it could be controlled clinical trials, or it could be community trials. So basically it depends upon intervention, administration of drug or vaccine, or dietary. So basically in controlled clinical trials, we are basically doing an intervention. So administration of drug or vaccine or dietary supplementation, or if there is any performance of diagnostic or therapeutic procedure, or there is introduction of an educational tool. So there could be any type of intervention or application which can lead to this controlled clinical trials. Apart from that, there could be preventional versus therapeutic trials depending upon the type of intervention. We will see that there are 4 or 5 types of interventional studies in oncology, and that will give us a broad idea that how in oncology particularly, it's not only the intervention can be therapeutic. It could be preventive intervention. It could be only quality of life assessing intervention. So the types of interventional studies are randomized control trial, non-randomized control trials, interventional studies without any concurrent control, pre-after studies, that is pre-post studies, then factorial study designs, and cluster randomized trials, as I have already spoken in short. So in randomized control trials, there is a group of participants who are fulfilling certain inclusions and exclusion criteria. They are randomly assigned to 2 separate groups, and they each receive a different intervention. So it's not necessary that each will receive some intervention. The second group may be a merely control arm also. Random assignment, it implies that each participant has equal chance of being allocated to the 2 groups that we are all aware. We don't need to go into details of that. And use of randomization is a major distinguishing factor and strength of this study design. So one very important aspect of randomized clinical trial is basically randomization. It provides, it removes usually the confounding bias, and it is a major distinguishing factor which distinguishes it and provides it more power as compared to non-randomized control trial. But the thing is, the randomization technique should be ideal. And in randomized control trial, the term controlled, it refers to presence of concurrent control or comparator groups. So these studies have 2 or more groups, and treatment and control. And the control group, there is no intervention and another intervention that resembles the test intervention in some ways, but lacks its activity. So sometimes if there is no intervention, patient can be merely a control. But sometimes if we introduce like placebo or sham procedure, so it lacks the activity, but it resembles the test intervention in some or the other way. So that is placebo control trial or sham control trial. We all are aware of these types of placebo control trials, like we all heard of Paloma 2, Paloma 3. So these are all placebo control trials. Or another acute treatment, that is the current standard of care. So all the trials of RCC, means predominantly renal cell carcinoma with COMPARTS study. So all those studies, they are basically the pieces trials. So these are basically comparing with the current standard of care. And the outcomes are then compared between the intervention and the comparator group. So this is the process of randomization. We randomize a group of individuals with similar clinical features or basically similar features which we wanted to study. So they are randomized to control and interventional group. And why is randomization important? So that all groups are as like as possible, and it provides the best way to prove the effectiveness of a new agent or intervention to that group. So some additional methodological features are often added to the study to improve further validity of a trial. So now what are these features? So we can see one by one. I will not go into details, otherwise in the interest of time. So there is allocation, concealment, blinding. Blinding is very important. So it could be double blinding, it could be single blinding. So these are all very important factors to reduce the selection bias. Intention to treat analysis, we will see when I will come to the clinical trial part. And measurement of compliance, minimizing the dropout is very important, and ensuring appropriate sample size. That is, there is a specific formula for that how we calculate the sample size so as to assign adequate power to our study. So different types of randomized control trials in oncology. So as I told that in oncology, we have lot of different types of clinical trials like treatment trials. So treatment trials, they test safety and efficacy of newer agents or intervention in people with cancer. The most possible benefit of treatment trials is early access to newer treatment, but the possible risk is occurrence of unknown side effects. Similarly, in prevention trial for patients who are at risk of developing cancer, the benefit is basically it allows early access to newer interventions, but there is a possible risk of occurrence of unknown side effects. The very well known prevention trial is chemo prevention trial in prostate cancer that we will be looking in the subsequent slide. And treatment trials I don't need to describe, because we know that majority of the clinical trials on which the approvals are based, they are treatment trials. So not about only treatment and preventive trials, there are different types of diagnostic trials, there are different types of supportive care trials also in oncology. We need to keep in mind all those things. Like quality of care trials are sometimes there which aim to improve quality of life for patients and families. And the possible benefit is early access to newer treatment, and the possible risk is discomfort and inconvenience to the patient. So most of the time, it's very difficult to get the patient into these clinical trials, because there is a possible risk that it may not benefit, the patients may not benefit from intervention, and these patients are usually only on supportive care and palliative care, so they may not agree to become a part of these intervention studies. Similarly, diagnostic trials, they develop better tools for classifying types and phases of cancer and managing patient care. And the possible benefit is newer technologies may be better and less invasive. So if we want to approve some less invasive newer technology for the possible diagnosis, so when we design such a trial, so it's a diagnostic trial, because in this trial we are not usually doing some therapeutic intervention or preventive intervention. And the possible risk is again discomfort and inconvenience, and it may require people to take multiple tests. Similarly, screening and early detection trial, we all know that screening trials are being conducted hugely in lung cancer and breast cancer, which assess new means of detecting cancer earlier in healthy people. And the possible benefit is detecting disease at an earlier stage, resulting in improved outcome. However, the possible risk is discomfort and inconvenience, and if imaging technique is used, exposure to X-ray or radioactive substances can be troublesome for the patient, as we have seen in the breast cancer screening trials, where there is a lot of apprehension of the patient for yearly mammography or annual mammography. Apart from that, there are genetic trials. So these trials, they determine how one's own genetic makeup can influence detection, diagnosis, prognosis, and treatment. And it broadens the understanding of causes of cancer. So it also helps in developing targeted treatment based on genetics of the tumor. And we all are aware of numerous BRCA studies which have been done. The possible drawback is picking up unnecessary genetic information, which may add to anxiety without any therapeutic or preventive implication. So that is another drawback of doing non-NGS with non-selective NGS. So a lot of time we pick up unnecessary genetic mutations and genetic informations for which we are not conveying anything to the patient. So these are the major drawbacks of these genetic trials. So placebo versus drug, I think we have seen this. That placebo are almost never used, and placebos are used only when there is no standard treatment exists. Whenever there is a standard treatment, if we are establishing some new standard of care, we have to compare with the standard of care that we've seen. So quickly, I will just give you a very simple example of randomized control trial. So whenever we compare these two treatments, so is treatment A better than treatment B? So if you see with application of treatment A, if 17 people have recovered, and if application of treatment B, only 8 have recovered. So what are the common questions which comes to our mind when we do a randomized clinical trial? So out of these 8, why these 8 they recovered when the treatment B was given, when we are assuming that treatment A is obviously better than treatment B, and where the younger, stronger, or in a better condition than those who did not recover? Or if the treatment A is better, then why did these 3 didn't recover even when they received treatment A? Were they older, more feeble, or in a worse condition than those who did? So probably randomization, when we randomize the people, we don't, the investigator is not biased to give treatment to more sick individual. And this basically answers this question. So perhaps if treatment A is not better than treatment B, then this could be due to allocation bias, or this can be due to either assessment bias. So these types of biases, they keep on coming in randomized clinical trial. And when we do adequate randomization in a very controlled manner, we tend to reduce these types of biases. So if treatment A is not better than treatment B, then the results could have occurred by chance, and then we have to apply our statistical analysis to look whether this result is by chance or it is really a statistically significant result. So for all these questions, the effectiveness and efficiency of the clinical trial, it depends on response to each treatment arm whenever we assign some treatment, influence of other factors like age, gender, or lifestyle, number of patients, how patients are selected, how patients are allocated to treatment, whether it's a type of trial, whether it's a parallel or crossover trial, compliance of patient to treatment, and how data is recorded, analyzed, and interpreted. So parallel and crossover studies, this is very important to know. Apart from that, there are sequential, group sequential, and factorial. So this is the main difference between the parallel and the crossover design. So what is the main advantage of parallel studies is that when we assign certain population to assessment, first we see whether they're eligible and willing subjects, then we allocate to one of the treatment arm, either treatment A or treatment B, and we do assessment and data analysis, like simple what we did in the CDK inhibitors, majority of the CDK inhibitor trial. Now, two-period crossover study design, it is another type of intervention study where when we assign, so up to this part, it is similar to almost parallel study design till the allocation. But after a certain period of time, when we assign the patient to treatment A and treatment B, we again do assessment and we cross over them to treatment B if the patient is, and we cross over them to the either treatment arm, and then we again do assessments. The best example of two-period crossover design is the COMPARTS study was RCC, and a crossover study design which, if I'm not wrong, Titan study of apalutamide, their crossover was allowed, and the patients who were progressing on chemotherapy, they were allowed to receive apalutamide. So there was almost 40% crossover rates. So prevention trials and chemoprevention trials that we have seen in previous slide. So this was the trial which I wanted to emphasize, reduce study design. So there was basically telephonic basically clinical visits every 6 months, pre-randomization, then study entry, then randomization, and from randomization, the subjects were randomized to either dutasteride or matching placebo, 0.5 mg daily, and then 2 years till 2 years the biopsy was done. At 4 years the biopsy was done, and it was found that dutasteride, whether dutasteride is reducing the risk of developing prostate cancer or not. So this is a type of preventive oncology clinical trial. Quickly, we will see the advantages and disadvantages of RCTs. So advantages, bias and systemic error can be controlled, intervention, sample outcome can be controlled. Disadvantages, ethical problem. It's a very expensive and time consuming, and problems related to therapy change and dropouts. So it's limited in the possibility to generalize results. What are the major advantages of a randomized trial? There is a minimal bias when the well-designed will optimize comparability of treatment arm, and it can document OS advantage. So which is the gold standard for clinical benefit in any of the oncology drugs, we all know, and it is optimal for documenting safety and toxicity of experimental treatment. It is commonly required for full FDA approval. However, it's not like randomized clinical trials are always required for full FDA approval. That I will be coming to it in second part of my presentation. So major limitation of randomized control trial is excessive time to accrue. It's very difficult to perform a randomized clinical trial for rare cancers, as it was already asked in chat box, and low frequency molecularly defined subsets of common cancers are very difficult to put these patients into randomized clinical trial, because you will not get that adequate number of subjects to randomize them. There is a strong potential for benefit of study agent, patient dropout on control arm, and crossover within or external to the study. And ethical challenges. Sometimes ethical challenges, they can come, but now we have in all our institutes, we have proper ethical committee and institutional review boards which tend to sort of minimize these limitations. So are RCTs feasible? New drugs, are RCTs feasible or critical in all situations? So I must say no. RCTs are not feasible in all situations if you have a very new drug with very strong biological rationale, like in lung cancer, particularly when we have ALK inhibitors, when we have EGFR inhibitors, they have got so much strong biological rationale in biomarker selected population. RCTs are not feasible. New drugs, it demonstrated unprecedented overall response rate in the setting of high unmet need. So there are certain tumors where there is high unmet need and there is no other effective treatment. And if the newer drug has demonstrated an unprecedented overall response rate, like I will be explaining you the role of Vismodegib. So it has shown unprecedented overall response rate. So in those settings, it's very much unfeasible to do a RCT. And there is an already approved molecularly targeted agent, which is being tested in that rare tumor histology, expressing the appropriate biomarker. So when somebody has developed the cogner of that molecular targeted agent, this new cogner molecular targeted agent may not read a randomized control trial because it's a rare tumor histology. So I will be explaining this complicated part based upon the examples of what actually we do in our oncology practice. But before that, I will just quickly touch upon single arm trials. So these are commonly the basis of accelerated approval of oncology drugs, because we all know this term accelerated approval. Lot of drugs, they have got accelerated approval, like atezolizumab for metastatic breast cancer, triple negative breast cancer. So that was again accelerated approval. So benefit, it requires fewer resources. There is a less time to complete, and it is appropriate basically in refractory population. And it is easily understood by target patient population because it's a single arm trial. So you don't need to explain to the patient that we are gonna to randomize you, and it will be a blinded study, it will be a double blinded, it will be a triple blinded. So it's very easily understood, not by the target patient population, but by the investigator and by the doctors also. The limitation is defined patient population frequently is not comparable to their historic control. And if response rate is marginal, it may not reflect the true clinical benefit. And there is poor characterization of safety. So that was all single arm study, that is non-randomized clinical trials. So in these trials, participants, they are assigned to different intervention arm without there is a non-random procedure, and this may be based on investigators' convenience or whether the participant can afford to a particular drug or not. But these non-randomized clinical trials, they usually don't form the backbone for FDA approval of a newly tested drug. And although such designs can suggest a possible relationship between the intervention and outcome, but it is highly susceptible to the bias because it is based on investigators' convenience and it is based upon investigator's choice whether participant can afford a particular drug or not. So single arm trials supporting the approval unprecedented effect or overall response rate if it is observed in the setting of high unmet need, if clinical trial patients have been well characterized and enabling and if they are well characterized that they represent the target population, and if experience already exists in the sufficient number of patients to allow adequate assessment of risk benefit relationship. So in those exceptional scenarios, single arm clinical trial, they supports an approval. So now we come to high magnitude and durable response rate in single arm clinical trial in oncology. So as I told that it is used for accelerated approval. So when the overall response rate is suitable for traditional approval as a direct clinical benefit or as an established surrogate marker. So I will just quickly go in the interest of time. I will go to my examples. So what is the change which is happening with old paradigm? That if there is no molecular enrichment, like if we consider a case of lung cancer, initially we used to always compare with a platinum-based doublet with platinum-based doublet plus either either angiogenesis inhibitor or some targeted therapy. So it was a high-risk phase 3 clinical trial. But now what is new paradigm? If you have a molecular enrichment, if you have there is a targeted therapy which has a larger effect on durable overall response rate, since it's a low frequency mutation, high risk, high screen failure rates are very much, there are very much chances of high screen failure rate, and it has large effect on responses in early clinical study. So is there any clinical equipoise to conduct a randomized clinical trial? So see, what are large and durable overall response rate that I wanted to highlight. So it directly attributed to drugs effects as a spontaneous regression of cancer. Why not PFS and OS in single arm trial? So it's difficult to discern this drug effect from patient and disease natural history. So if you see vismodegib response in the skin cancer before treatment and after treatment. So here the basically what I wanted to tell is the duration of response and the importance of response and the impact of response is that, and the tumor is so rare that we cannot always do randomized clinical trial to prove the efficacy or effectiveness of vismodegib. Similarly, whenever we talk of response in a clinical trial, it can differ both qualitatively and quantitatively. There are some responses which you can just see mere from any part of the room, like this response. You don't need to put an arrow to pinpoint this response. But there are certain responses where you need to put an arrow and prove the efficacy of this drug. Like this lymph node shrinking, you have to pinpoint the arrow and you have to show. But here, this improvement in lung window, you don't need to pinpoint the arrow because it can be seen anywhere from the room. So these types of responses can be qualitatively so high. And similarly, in this with this background, I would like to tell you about the crizotinib experience. So we all know that crizotinib is a highly active agent against EML translocated non-small cell lung cancer. So it was a mouse model for EML positive lung cancer, and these were the responses which practically we can see from every corner of the room. We don't need any arrow to point out the responses to these drugs. So from discovery to FDA approval, the discovery of EML fusion gene in 2007, first clinical response in positive tumor in 2008. The phase 3 clinical trial was initiated in 2009, and in 2011 itself, crizotinib got FDA approval. So this is a rapid timeline because of the incidence of tumor, low frequency of ALT translocation, and durable and sustainable response, as I told in my presentation. So to conclude, the old paradigm was always we need to randomize our patients to either drug or control. But as I told, that it not necessarily be only therapeutic trial. It can be preventive trial. It can be quality of control. It can be quality of life trial. It can be screening trial. It can be preventive trial. It can be diagnostic trial in oncology. And then after randomization, we prove the benefit for the drug approval. But now in new paradigm, if it's a rare tumor subtype, if it's a low frequency disease, single arm trial, we randomize to we assign to targeted therapy, and we prove the effectiveness of that therapy on the basis of overall response rate. Quick 2 words on barrier to clinical trial. So barriers to clinical trial. So general barrier to clinical trial, many of the patients means they do not know what clinical trial is. Fear of research, historical abuses, fear of that treatment, ideal treatment will be withheld, lack of access, basically lack of access to clinical trial, which is, I think, which is a very, very important barrier. Personal and practical obstacles, cost and insurance concerns, cultural influences, unwilling to go against doctor. Sometimes the doctors, they suggest that don't participate in clinical trial, and study design eligibility criteria like lot of comorbidities, they are excluded from the trial, and low health literacy. So all these factors, I'm sure, means whoever clinician is listening to this presentation would know that he would have exactly faced this issue. Lack of access to clinical trial is something which I have faced many times, and there is a website CTRI. I usually log into the website and I provide my patient about the sites where they can access to those clinical trials. But still, because of these all issues, it's very difficult to convince the patient. And in the latest survey, somebody can correct me if I'm wrong, only 5% of the patients who are actually eligible for clinical trial, oncology clinical trial, they opt for oncology clinical trial. It's not only about patient, healthcare provider barriers are also there. They are unaware of clinical trials. Most of the people, not most of the people, but many of the healthcare, they have unwillingness to lose control of patient care. They don't want to lose their control. So most of the time, in fact, in different hospital settings, we see that patients are not being referred to the site of clinical trial because they don't want to lose their patient. Still, some clinicians, they believe that standard therapy is best, and why to subject patient to clinical trial? There are administrative burdens. There is no enough time to discuss option with the patient. That is again very common scenario. And sometimes the clinicians, they judge that patient would not be interested. This is basically a healthcare person's judgment without even explaining everything to the patient. So these are, I'm not telling that these are the barriers everywhere, but yes, these are indeed common barriers. But what are the benefits? Early access to new treatment, active role in all healthcare, and participation in advancing medical knowledge. So protecting participants is also very important. And now we have institutional review boards and data and safety monitoring boards, which ensure integrity of data, minimizes risk, and they can stop study if necessary. So now we come to the last part of my presentation. In the interest of time, I have to rush through the middle part. So real world evidences and interventional real world evidences in regulatory processes. So we all know, the previous speaker has already covered that how real world data is collected and how they are being applied in our clinical practice. So the role of real world data comes when we see the randomized clinical trial and we fit all our individuals into one size. But when it comes to real world study, the first question we ask is, does one size fits all? So what is real world evidence? Why do we need real world evidence? So this is a sort of clinical trial where we keep everything ideal. We exclude all unfit individual, we exclude all elderly individual, we exclude all people with comorbidities or patients with comorbidities. And these are certain real world evidences where you don't have any controlled condition. You have to actually face the ball in the field, and you have to play as per the demand. So this slide, I will just quickly show that randomized clinical trials, which we have studied till now, the relevance of these studies are basically internal validity. But for real world evidence, the relevance is clinical practice, which as rightly asked again and again, that what is the major use of real world evidence is the clinical practice, because there is wide, unrestricted, and there are only few exclusions. While in randomized clinical trial, it's a narrow population with extensive selection criteria. So this is something a patient population looks like in randomized clinical trial, and this is actually what we see in our clinical practice. So real world evidence can address patient groups for clinical importance. So there are strict inclusion and exclusion criteria in clinical trial. We have seen all these things, so I will just quickly skip this slide. Now, what I wanted to present with this example, that there is improved overall survival with Mosaic trial. We all are aware of this trial, Mosaic trial in adjuvant colon cancer. So let me tell you about this. So when this Mosaic trial it was done, so they found that oxaliplatin based chemotherapy remains the mainstay of adjuvant treatment for basically early stage CRC patients. So all stage 2 and stage 3 CRC patients, they were randomized to either fluorouracil or FOLFOX based chemotherapy, and found that FOLFOX was found 71% 10 overall survival as compared to 67% with fluorouracil and leucovorin. And they came to the conclusion that oxaliplatin must be added to fluorouracil leucovorin. Similarly, ACCEPT study was done, and it was basically a non-inferiority trial. So addition of oxaliplatin significantly improved 5-year overall survival and 6-year overall survival we have seen. But the question is, are all patients included and addressed? And in real world practice, can we fit all patients based on this study? So the eligibility criteria of Mosaic trial was 18 to 75 years of age, prior chemotherapy, immunotherapy within 6 weeks of surgery patients, they were allowed. And similar was ACCEPT study. The trial was open to all patients aged 18 to 75 who underwent surgery within 8 weeks of randomization. So there was a thought process that what to do with individuals who are more than 75 years of age. And then there came this meta-analysis which shown that actually there are a lot of meta-analysis, but this was one which I wanted to highlight. So their patient population importantly represented a more real world age distribution, and 68% of the patients, they were more than 75 years of diagnosis, 75 years of age at diagnosis. And it included patients with greater comorbidities and risk, which typically allowed in clinical trial. And they came to the conclusion that the effect of adjuvant chemotherapy, whether we add oxaliplatin or not, it remained there irrespective of the age and irrespective of the comorbidities. And the patients, they died of colon cancer more if they are not being given adjuvant chemotherapy as compared to other comorbidities. So this is where the real world interventional data comes into clinical practice, where we find the randomized control trials, they excluded our population, which we are going to see in clinical practice. Same is the case with Palbociclib trial. I'm not going to go in detail. Palbociclib and letrozole, Paloma 2, Paloma 3 trial, we are very well aware. But again, the flaw was very carefully selected patient population. There was a stringent selection criteria. It was not applicable to selected patients in clinical practice, and there is no consideration of comorbidities and cost effectiveness. But when we come to real world evidences across all US and European nation, we have IRIS, Flatiron, Polaris, and expanded access program. And similarly in India, we got this opportunity to publish our data, multicentric real world evidence of Palbociclib. This was from 2 apex centers of India, combining Rajiv Gandhi and BLK. And we published it, and we found that our patient population was very, very heterogeneous. And in fact, the eldest patient in our patient population was 89-year-old, which was missing in the Paloma 2 and Paloma 3 data. So real world evidence can provide additional data to improve drug delivery and drug effectiveness, because we all know efficacy and effectiveness, there are two different terms. Efficacy is basically the extent to which under ideal circumstances an intervention can produce more benefit than harm, while effectiveness is the degree which under usual circumstances of routine healthcare practice an intervention can result in more benefit than harm. So this is where real world evidence can provide additional data as compared to randomized control trial. Real world evidence can assist with health assessment and funding decisions, because in real world when we do a real world evidence, we actually take our funding decisions also into consideration, whether the patient can afford the drug or not. While in randomized control trial, everything is being provided by the investigator, by the basically the funding sources, they are not taken into consideration. So Canada is one particularly unique country in that universal healthcare system allows for data capture from basically cradle to grave, that any repository containing health data spanning a patient's entire lifetime they used to collect, and then after drug approval, they provide the impact of that drug on patient's quality of life. So the role of real world study in regulatory process has been to supplement existing approval and not as a central component of initial drug application. So they are most frequently applied for post marketing assessment, risk management, and assessment of benefit risk across the drug life cycle. So real world evidence in regulatory decision making, as I've already told, that regulatory context and clinical context has to go together. Data consideration and methods consideration has to go together. Finally, we come to the conclusion that whether our real world study is basically fit for purpose or not. So matching data sources and appropriate methods to the research question and the regulatory and clinical context will result in different types of real world evidences for different use cases. But yes, it can be used in regulatory decision making. So it was emphasized by one of the researcher, Levy. So she emphasized that real world evidence and clinical evidence, clinical trial evidences, they are not in conflict, but rather they are complementary. So clinical trial information, development of rigorous real world data generation, and real world evidences, they improves the pragmatism and relevance of clinical trial. So these both things, they go side by side and complementary. So to conclude, it is not always possible to perform randomized clinical trial, and rigorous single-arm clinical trial can be used to support approval in certain circumstances. Improved science and technology has led to development of therapies with well-understood mechanism of action, well-defined population, and clear tumor responses that exceeds those offered by existing therapies in terms of not only magnitude, but also duration. Identification for appropriate historical controls, they are very important, which is a key issue for single-arm trial to support regulatory approval. And not only single-arm studies, but also real-world studies can be used for regulatory approval under certain circumstances. As I told, rare tumors, exceptional response rates. So it was a really exhaustive presentation, and I thank you all for listening to it, and thanks to the organizer once again.